Last speaker in this symposium, Dr. Ben Parker. He's a consultant rheumatologist at the Callaghan Centre of Rheumatology at Manchester Royal Infirmary, United Kingdom. And we have a recorded lecture because he's unable to join live today. And Dr. Chaturika Dandeniya, a senior lecturer, Department of Medicine, University of Peradeniya, consultant rheumatologist, will be there to answer your questions at the end of this recording.
Hi, good afternoon. My name is Dr. Parker, Ben Parker. I'm a rheumatologist from Manchester, and I've been asked to give an overview of systemic lupus. I'm a consultant rheumatologist in Manchester University Hospitals and run a tertiary lupus service that covers the northwest of England and have an active research program in lupus involving both observational, experimental medicine and clinical trials. So I thought it would be useful to hang this on a case of a patient who's a real patient of mine and use this to illustrate some important lessons learned when managing patients with lupus, particularly those who are not used to seeing complex lupus patients, so more of a general overview. So we'll cover some of the basic epidemiology, clinical features and diagnosis, and then introduction to the management of lupus. Lupus is the quintessential, uncommon, multi-system, chronic inflammatory autoimmune disease that is characterized by autoantibody production against components of nucleic acids, such as double-stranded DNA, and it is well known to have a relapsing and remitting disease course that features both inflammation, such as rashes and arthritis, and damage that may be due to inflammation, treatment, or comorbidities. Lupus runs a heterogeneous clinical presentation, which is challenging to diagnose and manage, and equally challenging to research. Just to remember that lupus sits within the connective tissue diseases and has overlapping features with many of them, such as Sjögren's syndrome, mixed connective tissue disease, myositis, for example, and many patients evolve over time, often from an early or undifferentiated connective tissue disease. Antiphospholipid syndrome is common in lupus, and therefore the CTD family should be thought of as an overlapping spectrum of disease. Epidemiology informs how we manage patients, in as much that who is more or less likely to suffer with lupus or more severe lupus. And again, many of you will know that lupus has an excessive ratio of female involvement, with ratios of anything up to 12:1 observed in a number of studies, with a peak age of onset in the childbearing years, and many incident studies showing the peak onset in the mid-30s. There's obviously a clear ethnic gradient in both the prevalence and severity of lupus, with Caucasian populations having the least severe and the lowest prevalence. Several studies have shown that lupus nephritis, a common and serious presentation in lupus, has the highest prevalence of renal disease in patients of Chinese and Afro-Caribbean origin compared to white and Indo-Asian populations. So the first introduction to our patient is in January 2014, when a 26-year-old female of Indian heritage presented to a hospital nearby with an acute digital vasculitis with critical ischemia of the left third digit. In the few weeks before this, she'd had onset of small joint arthralgia, rash to the face, and constitutional symptoms of tiredness and fatigue. She actually presented with a longer-term history of Raynaud's phenomenon that hadn't caused complications, and was noted on admission to have a positive ANA, strongly positive anti-dsDNA, but also more broadly positive ENA profile with a SM, chromatin, RNP antibodies and a low complement. On the basis of her clinical presentation, antibody positivity, she was diagnosed with lupus acutely. She was managed with iloprost as a inpatient, which is a potent vasodilator for her critical ischemia, and recovered well. She was also started on steroids, hydroxychloroquine and MMF due to the other concurrent inflammatory symptoms of rash, arthritis, and patients with critical ischemia often have underlying small vessel vasculitis as well, and responded very well and remained under local follow-up after discharge. What does this case tell us? Well, it tells us what we already know from the previous slides, that she was young. She was in her mid-20s when her symptoms started and therefore was of childbearing age. Pregnancy plans are always important when talking about treatments and manifestations. And we also know that she was of the Indian subcontinent heritage and therefore possibly had a worse prognosis and a higher risk of renal disease than if she were a Caucasian patient of a similar age. Whilst this doesn't necessarily change how we manage individual patients, it's worth remembering the epidemiology of who gets internal organ disease to make sure that we're aware and observing closely. So what are the clinical features of lupus? Well, there are many potential clinical features. They often cluster in an individual, so people talk about skin and joint disease, lupus nephritis, and severe internal organ disease, and it's often found that severe features are more common in non-Caucasians, as already discussed. Some features are very difficult to diagnose, but often dictate therapy and outcomes, and renal disease often needs a biopsy to accurately diagnose and prognose, and CNS disease is characteristically very difficult to diagnose in patients, depending on the abnormalities and clinical presentation. So skin lesions in lupus are multiple. The classic malar or butterfly rash is seen in many but not all. A history of photosensitivity is key in many, and subacute cutaneous lupus, as seen here, is a classic sign. Patients may suffer with panniculitis, and alopecia is common, but generalized hair fall is also a common symptom of disease activity. Inflammatory arthritis is a hallmark of many patients with lupus, but the characteristic Yakud's arthropathy is a deforming, non-erosive and correctable arthropathy that can look clinically very similar to rheumatoid arthritis, but is not erosive. Lupus serositis is common, so patients present with pleurisy and pleural effusions, pericarditis and pericardial effusions, and less commonly with abdominal serositis. Renal lupus is a major driver of comorbidity, poor prognosis and treatment, and therefore is very important to diagnose as soon as possible, but as you know is often asymptomatic until patients present with renal failure, and therefore monitoring dipstick for proteinuria and hematuria is a key fundamental tool of lupus management. Cardiac manifestations are numerous and probably more common than most people think. Pericarditis is often symptomatic as pericardial disease, and myocarditis can complicate systemic flares, probably with a higher prevalence than most people would be aware of when using cardiac MR, for example. The Liebman-Sachs steroid endocarditis can occur in patients with active disease, which can lead to valvular heart disease as well. Raynaud's phenomenon is common and may result in ischemia and chilblains on a regular basis. As you know, around 30 to 40% of patients with lupus will have the antiphospholipid syndrome as well. Many more will have antibodies but no clotting tendency. Livedo reticularis can occur in patients with antiphospholipid syndrome, and a history of pregnancy morbidity, poor pregnancy outcomes is a key manifestation to pick up on as well. So what happened to our patient? Well, she flared in the February of 2015, around a year after her initial diagnosis, when she presented acutely unwell to my hospital with symptoms of chest pain, breathlessness, and was found to be hypotensive and tachycardic. She was admitted direct to the critical care admission as she had an acute kidney injury and was hypoxic. And because she had lupus, she had an early test of her immunology, which showed low complement C4 and very high anti-double-stranded DNA antibodies. Echocardiogram on the critical care unit showed a small pericardial effusion, but a significantly reduced ejection fraction at 22%. She had elevated creatinine kinase and troponin T, and a cardiac MR done shortly after we met her showed diffuse severe biventricular dysfunction with an erythematosus left ventricle. Overall, the clinical features were consistent with an acute lupus myocarditis, resulting in cardiomyopathy. When we spoke to the young patient, it was clear she'd had very poor adherence to her treatments in the run-up to her admission, having stopped both the MMF and the steroids and been very intermittent with her hydroxychloroquine. During that admission, she was treated with high-dose IV steroids. Once that had finished, she'd started on high-dose oral steroids, which were tapered over time. And we talked to her about her pregnancy plans, as she'd already had one child. And we decided that due to the severe manifestations she presented with, she would benefit most from cyclophosphamide using the low-dose urolupus regime, which minimizes exposure and reduces toxicity, but does have a smaller risk of infertility in the future. And we had this fairly frank discussion about her family planning issues. She was also started on heart failure medications, and the plan was to restart the mycophenolate mofetil after the cyclophosphamide, as she hadn't flared whilst taking it. She'd flared because she'd stopped it. So what does this tell us about lupus? Well, it tells us that new manifestations can develop over time. So she presented with a history of rash, arthritis, and Raynaud's phenomenon with ischemia, and then she flared with lupus myocarditis. It's therefore important to assess each new feature fully and ensure the mechanism of that feature is understood. Attribution to this being a lupus manifestation can be difficult in certain circumstances, but is very important when deciding therapy. And if a woman is of childbearing age, we always need to ask their plans when thinking about treatments, as all the treatments offered to this young lady so far would be incompatible with a pregnancy unless stopped and changed. So how to diagnose lupus? Well, there's no single diagnostic test. As all rheumatologists know, diagnosis of any rheumatic condition is on the basis of clinical history that is supported by examination findings and investigation results. As a result, diagnostic delay does persist for many individual patients with lupus, particularly those who have less obvious clinical manifestations. And it's worth remembering that classification criteria, such as the ACR criteria or the SLIC criteria, support research and ensure consistency of cohorts, but are not to be used as diagnostic criteria. Immunology is key, and it's important to try and demonstrate some kind of immunological abnormality when diagnosing lupus. And often people have positive ANA and ENA profile, positive anti-double-stranded DNA, C3, C4, and often abnormal immunoglobulin levels. It's worth checking antiphospholipid syndrome markers at diagnosis. But moving forward, once diagnosed, then assessing activity uses a slightly different set of blood tests, including inflammatory markers, although CRPs usually mean infection rather than lupus flares. We monitor anti-dsDNA, C3 and C4 regularly, as well as a urine dipstick, but only repeat the ENA profile if a new manifestation occurs or if patients are planning a pregnancy. There are a number of classification criteria now used for research in lupus, and this is a classic one from 1997, the ACR criteria, where patients needed to fulfill any 4 of 11 of these clinical features, and other criteria sets have attempted to ensure that immunological disorders are imperative when diagnosing, such as the SLIC criteria, and also start to use biopsy results, particularly renal biopsies. So, for instance, the SLIC criteria in 2012 needs 1 clinical and 1 immunological manifestation and allows lupus nephritis to meet the classification criteria regardless of other systemic features. The ACR EULAR criteria 2019 has a weighted score basis, but also must be ANA positive. When managing patients with lupus, it's important to determine a level of disease activity to determine what is the next best treatments. Definition of disease activity can be thought of as a reversible clinical or laboratory manifestation reflecting an immunologic and inflammatory manifestation of lupus at a specific point in time. Now, what this means is in the clinic, we treat and manage inflammatory conditions in the broadest sense with anti-inflammatory medications, be that steroids or immunosuppression. It's often an informal measure in clinic. People are active or inactive, in remission or not in remission. And clinical trials and studies of lupus use formal disease outcome metrics or endpoint assessments to try and capture this in a numerical way. When assessing disease activity, it's worth remembering that the pathogenesis of each manifestation may vary. Some disease symptoms are caused by inflammation, rashes, lupus nephritis, for example, or vasospasm, such as Raynaud's, thrombosis, such as those seen in antiphospholipid syndrome or in inflamed blood vessels, and can often lead to fibrosis, which is often a manifestation of damage, so scarring, alopecia, for example. The key assessment to direct therapy is always activity versus damage and inflammatory manifestation versus non-inflammatory. The treatment paradigm in lupus is to accurately and timely diagnose patients, ascertain organ involvement, decide on which type and target of therapy is needed, and this is based on levels of disease activity, the organ involved, and individual patient factors, to achieve control of disease activity, and then move towards a monitoring for relapsing or damage-related problems, side effects of treatment, and the evolution of comorbidity, and then eventually, at some point, rationalizing therapy. So how did our patient do? Well, between 2016 and 2017, she responded well to her cyclophosphamide and restart of MMF, and felt so much better, in fact, that she stopped turning up to appointments, both with myself and cardiology. I'd seen her in May 2016, and this she was asymptomatic. She had normal serology, having had very abnormal serology before, and a repeat cardiac MR showed no residual inflammation or scarring, but a persistently reduced ejection fraction at around 45%. The lady was about 28 at this point, had a young child, but she was back at work. So we talked about the optimal treatment paradigm. What's the actual treatment outcome? Well, often flares complicate any point in the progress through towards treatment rationalization. And so it was with our patient. So in 2017, she had her second flare. She was keen on further pregnancy, and to cut a long story short, there was lots of planning and discussions around what to do, as around this time she had a slight uplift in her proteinuria levels, probably related to declining adherence to her mycophenolate. And whilst planning her pregnancy between ourselves, the renal physicians, and the joint rheumatology obstetric clinic, she became pregnant. She had been taking MMF in the run-up to that pregnancy, and had a rising proteinuria at the time she got pregnant. So a lot of conversations were had around the safety of proceeding, but she was adamant that she was going to have this baby. So the management of her pregnancy, which I'm not going to spend too long talking about, as that's a talk in its own right, was hair-raising at times and complicated all the way through. But essentially, she had persistently active lupus nephritis, requiring high-dose steroids and continuation of azathioprine as an immunosuppressive agent throughout. She had a number of unplanned admissions into the maternity hospital with infections and disease flares, and was in antenatal clinic every week throughout her pregnancy. She had persistently high proteinuria throughout, and as a result, her baby failed to thrive with intrauterine growth restriction, and she was induced at 34 weeks due to the onset of placental failure. However, despite all of this, the baby did very well, and so did she once the delivery had happened and we were able to control her disease better. However, 6 weeks after her delivery, she was admitted into the acute adult unit with a recurrence of acute anterior chest pain and breathlessness. Initial investigations excluded a pulmonary embolus, and her lupus serology was actually relatively stable. Repeat echocardiograms showed a reduced ejection fraction back down to around 20%, and a repeat cardiac MR showed no acute inflammatory change, and the cardiologist diagnosed this as an acute postpartum cardiomyopathy on the background of a previous cardiomyopathy. So this was not a relapse of her lupus myocarditis, and therefore she was continued on her background immunosuppression of MMF and hydroxychloroquine, and her heart failure medications were optimized. So the initial management of lupus, as we've already seen, is to establish the diagnosis and try and determine the likely prognosis based on some basic epidemiology and pattern of disease at presentation. Simple lifestyle measures are important but often forgotten, so things such as avoiding the sunlight if any signs of photosensitivity, and using symptomatic remedies as required. Almost everybody needs some form of treatment, and that is dictated to by organ involvement and disease activity. So patients may evolve through antimalarials and low-dose steroids through immunosuppression towards cytotoxics and biologics, but at any point might skip a step and go straight to that. So, as we talked about with our treatment paradigm, flares keep happening, and in January 2019, our patient had the worst flare she'd had so far when I admitted her from the clinic. Again, she'd had poor adherence to her MMF, and she'd become unwell and breathless with a pitting edema peripherally. Within 12 hours of me admitting her, she was on the intensive care unit, ventilated with heart failure, acute kidney injury, high ESR and low C3, and a deteriorating cardiomyopathy with an ejection fraction of around 10%. During a long inpatient stay over 6 to 8 weeks, she developed a dense right hemiparesis, and when woken up was aphasic. An MR scan of the brain showed multiple acute CNS lesions. She had a very active urinary sediment with high protein levels, and overall, on the basis of an 8-week stay, she was diagnosed with acute CNS lupus with a CVA, acute lupus nephritis with an acute kidney injury, and a deteriorating non-inflammatory cardiomyopathy. She was managed with 5 cycles of plasma exchange, IV cyclophosphamide again, her second course, high-dose IV steroids, and over a 6-week period, she actually recovered remarkably well. She was eventually discharged home to her 6-month-old and 4-year-old child, and continues to be very well ever since. This admission scared her, and as such, her adherence throughout the entire COVID pandemic and beyond has been good. She's stable, her serology is normal, she's had no more flares, and she's back at work. So lots of lessons for me from this, but also for others, I hope, that patients who flare can develop worsening or existing inflammatory lesions. So in this particular flare, she had lupus nephritis, which was a pre-existing condition that had flared postpartum. She had damage-related deterioration to her cardiomyopathy due to just generally high level of systemic inflammation. She developed a new inflammatory manifestation with CNS lupus, but also a new thrombotic lesion with her CVA. And in this case, in a patient who is very, very ill, several mechanisms may occur at once. So in this case, she had thrombosis, inflammation, and damage all happening at the same time. If you mapped her disease activity over time, which remember is a reversible score, 0 being in remission, and anyone over the with a score over 10 would be considered very severe activity. Her 3 flares all resulted in a SLEDAI score of greater than 10, and her most recent flare with a SLEDAI score of 30, indicating very, very high levels of disease. But actually, with treatment and good adherence, her disease activity can almost be eradicated most of the time. However, her damage score, which is non-reversible, has continually escalated over time. Anyone with a damage score of 1 or 2 is considered to have severe and poor outcomes over time, and her damage score is now escalated to 6, which in a young woman of now 32, 33 does indicate a reduced life expectancy. So overall case history, this key lessons from my point of view is that disease activity in lupus is a key thing to identify, as it is reversible, and appropriate treatment needs to be offered. Patients who accrue damage is irreversible, and damage can be due to lupus. The treatments that we use, such as steroids, or the evolution of comorbidities, such as cardiovascular disease. It's worth highlighting again that disease activity will result in damage if it's not treated, and that all lupus manifestations and patients with symptomatic lupus need to have a series of assessments in order to correctly attribute mechanism of that symptom.
I'd like to thank Dr. Ben Parker for that comprehensive overview about systemic lupus erythematosus. And Dr. Chaturika Dandenia is here with us all the way from Kandy. If you have any questions, you can ask from Dr. Dandenia. Dr. Chaturika, I would like to ask, with your experience, are we missing the diagnosis of SLE in our day-to-day practice? And by the time we diagnose, whether we are too late?
That is actually a very good question, something that we have been pondering for a long time. So, if to answer your question, are we missing the diagnosis? In a way, yes. Because for one reason, the diagnostics are not very easily available and accessible. So in his the case study that Dr. Ben Parker was showing, he showed an impressive array of many antibodies that they had done to diagnose this patient. If we look in our setup, even accessing an ANA for the basic diagnosis is extremely difficult. So that is one reason. And a second reason is, being a tropical country, we have so many infections. And as we know, TB, like SLE, has manifestations that closely mimic many infections. So by the time they go through so many medical teams and then all the differentials are excluded and all that, what happens is what Ben said, like accrue damage due to the disease by the time the patient presents to a rheumatologist with the diagnosis of SLE finally, or when the diagnosis is made, like much of the damage has already happened. So are we missing SLE? In a way, yes, but it is due to understandable reasons. So that is what we are trying to avoid by educating the masses more about SLE. So try to refer as early as possible. And as he said, entertain the clinical suspicion. Always have it in your differential diagnosis, have the clinical suspicion. And our patients, yes, as he said, Afro-Caribbean, we are not as bad as Afro-Caribbeans when it comes to the disease phenotype, but we are much worse off than Caucasians. So our patients have pretty severe disease. So what I would like to tell to the audience, if you suspect, please refer as early as possible, because treatment is possible, and most of the treatment options that are available for SLE we have in Sri Lanka, except for a few medications that are very new biologicals, all the others we have. It's just a matter of diagnosing and starting treatment appropriately and on time.
So as we know, SLE is kind of an inflammatory, autoimmune kind of a disease. During pregnancy, the inflammatory diseases go into a remission. What's the usual way? But in this case scenario, it had some different other manifestations. What is the natural history? Do we have to worry or can we relax?
That's an excellent question, actually, because usually in pregnancy, we expect all the autoimmune conditions to die down, as she said, because pregnancy is a kind of a state, it's a relatively immunosuppressed state, because the baby is half parasite, it's half DNA from another person. So your body has to go into a relative immunosuppression to tolerate the baby. So that is why most of the autoimmune diseases, we actually see that they go into a remission during pregnancy. SLE also, it's the same, I can say, because usually what we say is the 1/3 rule. 1/3 will go into a remission, 1/3 will remain the same, 1/3 can worsen. And if we look at those who worsen during pregnancy, one is patients like this. Those who have nephritis, renal involvement, particularly active renal disease, prior to getting pregnancy, within the 6 months before they get pregnancy, if they have active lupus nephritis, very likely that they will worsen. If we go back to our very basic physiology of pregnancy, we can understand why. Because during pregnancy, you will remember that the mother's kidneys will be working for the babies as well. So throughout the 3 trimesters, your GFR goes up, your filtration rate goes up to work extra, because your circulation goes up, you accumulate more blood during pregnancy to kind of get ready for postpartum hemorrhage, because we were not supposed to give birth in hospitals, in sterile environments. We were supposed to give birth in caves. We were supposed to be wild animals, primates. So to like be ready for that, our blood volume goes up. So in like accordance to that, cardiac functions will deteriorate. If the heart was involved before, like in this index case, she had cardiac lupus, so the cardiac function will deteriorate, renal function will deteriorate. So those are two key factors that will determine that the disease will be active during and just after pregnancy. So pregnancy is not impossible in lupus. So this is one thing that patients come and ask us, because most of the affected are actually young females of reproductive age. Pregnancy is possible, but it has to be planned. It has to be very well planned. They have the current advice is they have to be in remission for at least 6 months on non-teratogenic drugs before they are able to get pregnant. Then again, still, if they have had renal disease in the past, there is still a higher risk than average, higher risk than the usual SLE patients. So SLE patients who get pregnant needs extreme close follow-up. So I generally follow these patients up like every month until about 6 months. After that, every 2 weeks. Every 2 weeks, and then the last month, every 1 week. I have a special clinic for that because they need extreme close follow-up. It's possible to have a healthy baby, but you have to anticipate complications at any point, maternal as well as fetal.